Uh, now is Professor Vishali Gupta. I think she needs no introduction. She's from PGI Chandigarh and the current president of the IUSG group. Professor Vishali.
Thank you. So the topic for me is the choroiditis. What are the do's and don'ts? One thing you have to remember about choroiditis that there is a very close call between infection and inflammation. So how do we go about it? I'll show you example of this case. Now this is a patient. Uh, it's one of the white dots, if we call it, or you see the patches of choroiditis out there, and you do fluorescein. So look at the fluorescein very carefully. The fluorescein is showing hypo, but when we go to the late frames, it is showing a very uniform hyper. It's not that the edge is leaking. Now, this uniform hyper, when you see, this is suggestive of AMP, APM, PPE, which, by the way, we do not see very commonly in India. You look at something similar clinically. It looks similar, kind of, what I showed you, choroiditis, yellowish. Then you do the fluorescein. Fluorescein shows a bit difference. It's mostly mixed, but when you go to the late phase, you see this edge. The edge which is leaking, and there is dye which is coming between the affected and the diseased retina. Now see the edge here, it's hypo, becoming hyper with leakage. This is serpiginous choroiditis or serpiginous-like choroiditis. And we come to the third disease where I think I put the animation wrong. I'm not able to show the fundus, but it looks similar. And when you do fluorescein, you have a ground glass appearance. This is syphilis. So here is all the three of them together. This is yellow patch in the fundus. This is APMPP. This is yellow patch. This is serpiginous choroiditis. And this is the lesion which I wanted to show you, a placoid kind of a yellow patch. But look at the corrector of the fluorescein. This is syphilis. So this is what I meant to say, that there is a very close call between infection versus non-infection, because if you look at them, they all look similar. But there are very important imaging biomarkers as well as clinical biomarkers which you can pay attention to and get the appropriate test done, so that suppose you look at this patient which is actually a syphilis and you think it is APM-PPE and do not treat it, it's going to be a problem. You look at this patient of serpiginous and you think it is APM-PPE and do not suspect infection, it is again going to be a problem. Or you see a patient of APM-PP and think it is TB and unnecessarily treat him with anti-TB drug, that again is a problem. So how do we approach this patient? There are a couple of questions that should be asked about every patient of choroiditis that we see. So is it choroiditis or is it retinochoroiditis? Is there any associated involvement of optic nerve head? Is their clinical features fit into any known infection or non-infection? Is there associated inflammation? Uni or multifocal, unilateral, bilateral, systemic disease? What was the previous episode like? And even if the patient is on treatment or you have started the treatment, is it responding the way it should? Now, I'm going to give you one or two clinical examples on how you will ask these questions for every patient of choroiditis that walks up to you. This is an example of the first patient, a 29-year-old boy. He has received multiple intravitreal triamcinolones, oral steroids, even TB treatment for almost 8 to 9 months before he came to us. His vision here is counting finger, and you can understand that's not a surprise. Now, I asked you a couple of questions which you should be asking. So the first question was, is it choroiditis or retinochoroiditis? Well, this is retinochoroiditis. There was associated vitritis. It's an immunocompetent patient. It is unilateral. But the important question I also asked, what was the past episode like? Now let's look at the first episode. This is the picture that patient was carrying with him, and you will realize that most of the uveitis patients carry that huge file with them, which they are very keen to discuss with you, and somehow you don't want to look at everything in past. But look at this. This is how the patient comes. You may do a number of investigations, including vitreous biopsies. But if you look at what it was like in the first episode, the diagnosis is written on the face. It's a case of toxoplasma retinochoroiditis, which was missed as TB. Patient was treated for TB, patient was treated with steroids, and we ended up in a lesion like this. This should not happen if we know our very basic, humble stuff. We do not need omics or we don't need any of the fancy stuff to know that this is toxoplasma, and we have to give a specific therapy to this patient. So this patient eventually underwent vitrectomy and everything, and these are the toxocysts from the vitreous. Another classical example is this example. So if you look at the phenotype, it's periperipillary, pseudopodia-like, projecting from the optic nerve head, and there is no vitritis. Now this is what has been classically described as serpiginous choroiditis, which is of immune variety, and you see on autofluorescence, there is an active hyperautofluorescence at the edge. So this grows along the edge very typically, and when you see it, this is non-infective by and large. What we confuse it with is TB. TB is different. It is serpiginous like choroiditis. It is very different from this form. It has choroiditis, which is multifocal. You may have associated vitritis, associated anterior segment inflammation, which should not happen in the autoimmune variety of serpiginous choroiditis. Unilaterality is by and large common. If you see scleral involvement along with serpiginous like choroiditis, TB is a very, very likely diagnosis. So always keep that in mind. And when we do fluoresceins in ICG, you find typically the center of the lesion will be healing while the periphery of the lesion will be active. This is what is serpiginous like choroiditis, and this presentation one should always rule out infection, most commonly tuberculosis. For example, in this patient, Montes was 20/20, quantiferon was positive. He even had CT, but believe me, all the three is not common to have positive. Even if one or two is positive and you have the clinical phenotype, good to start treatment. And this is how these patients would respond to good treatment with anti-TB. So I think I will go to my algorithm instead of giving the whole talk, because I would like to spend some time here. So if it is a choroiditis, you first see what kind of choroiditis is it. Is it diffuse or multifocal? If it is diffuse, do a simple OCT and see if it is the retina involved or it is primarily the choroid involved. If it is the primary involvement of retina and choroid is just secondarily involved, it could be toxo or viral. If it is primarily choroidal involvement and it is diffuse choroiditis, it is serpiginous choroiditis. That could be autoimmune. I showed you an example, which is bilateral, no inflammation in the eye, and the lesions are mostly in the juxtapapillary region and they are not multifocal. If it is serpiginous-like, which is infective, mostly TB, is unilateral, there would be associated vitreous or anterior segment inflammation, though not always. Lesions generally begin in the posterior pole, they are multifocal, and you may have associated vasculitis. If it is an autoimmune, honestly, the literature does not say you have to investigate, so you can start the treatment and investigate if you do not find a good response to steroids. But if it is the infective kind of a phenotype, always investigate to rule out infectious etiology, TB being the commonest, at least in our country. If it is a multifocal choroiditis, again see, does it belong to a classical phenotype of Mutes, AMPI, PIC? If it is any one of those entities, there is no investigations in the first step, only if there is recurrence. Whereas if it is multifocal and has an atypical phenotype which you cannot fit into, always investigate to rule out the possible etiology. So these are the do's, and the don'ts are don't start a therapy blindly without knowing the exact